All right, so greetings to the kidney community. My name is Rashida Hall. I'm a nephrologist at Duke University that's located in Durham, North Carolina in the United States.
And my name is Marissa Battistel, and I'm a clinical pharmacist in Toronto, Canada. And I'm an associate professor at the University of Toronto, and also in Toronto. So today we are going to discuss a paper that was published a year ago from the Netherlands. And it was on the impact of polypharmacy on health-related quality of life in dialysis patients. So Rashida, what stands out to you about this paper?
Yeah, I'm really excited to read about this paper, and especially because of their emphasis on health-related quality of life. In fact, before I started really thinking about how medications may be causing problems for our patients, I was doing some research in health-related quality of life. And over the past few years, it's been more and more used as a patient-reported outcome. I think for many nephrologists, especially those who work in a dialysis setting, they're familiar with the kidney disease quality of life, or KDQL-36 instrument that's often administered in dialysis clinics at least annually. And so it's interesting to see that there's components of that tool that were used in this study. In particular, it's the SF12 PCS, or short form 12 physical component score that assesses physical well-being. And then there's the SF12 mental component score that gets at mental well-being. And the kidney disease quality of life tool acknowledges not only those global aspects of quality of life, but also those that may be specific to kidney disease, like the effects of kidney disease, the burden, as well as symptoms. And in fact, there have been other studies that would suggest that patients with kidney disease, or in particular those on dialysis, have even poor or more difficulty with maintaining a good quality of life because of their kidney disease. So this study uniquely really tries to point out whether medications, or at least the number of medications, may be playing a role in how patients perceive their quality of life. And so that's what they're finding, which is there is a connection. And now what is on us to understand is whether we can improve quality of life if we cut back on the patient's medications. I know, Marissa, you're a pharmacist. What do you see when you look at this paper?
Yeah, for sure. So it's not surprising to see the results, because our patients have many risk factors for polypharmacy. Age, multiple comorbidities, acute hospitalizations, multiple healthcare visits, which leads also to multiple providers. So I want to give an example of a case, in our dialysis unit. So this is an 84-year-old woman on hemodialysis for the past 6 months, secondary to her diabetes. She's a widow. She lives alone. She's had three falls this last year. She sometimes forgets things and gets a bit confused. And of course, her children are worried about her. This is typical of many of the dialysis patients. Here we have her on 20 different medications.
Right.
So how did this come about? Well, there's another phenomenon called prescribing cascade. And this is what happens is an adverse reaction is interpreted as a new disease. So a new medication is added. And this new medication also produces another adverse reaction. And this is also interpreted as a new disease. So another medication added, and so on. So how did this happen to our Mrs. P? Well, because she was a little bit forgetful, she started herself on Ginkgo. And we know that this can cause an increase in blood pressure. And so her family doctor had started her on some amlodipine and ramipril. Her friends say, well, you have a bit of high blood pressure. You should probably start yourself on some aspirin. She also goes to the pharmacy because she gets a bit of a cough from ramipril and starts herself on a cough suppressant. So this is just the beginning of the prescribing cascade, but you can see how starting one, you think, innocent medication, and how it can cause a cascade of events causing polypharmacy. So I also understand you've been doing research related to medication problems in dialysis patients. How do you see your work could address this problem?
Yeah, so Marissa, I I didn't introduce myself as a geriatric nephrologist, but my area of interest is in helping older adults with kidney disease. And in particular, while a lot of my work around quality of life is looking at how to improve their quality of life, I'm also learning that medications can contribute to geriatric problems. If you can see on this slide in the far, if you look at these black boxes here, that older adults can have shared risk factors related to cognitive impairment, functional impairment, impaired mobility that can increase or contribute to the experience of geriatric syndromes and frailty, which then can lead to poor outcomes like dependence in their activities of daily living, disability, institutionalization, or even death. And what could potentially be contributing to this process is potentially inappropriate medications. So on the next slide, we point out these potentially inappropriate medications, or they're abbreviated as PIMS. There's some of these medications that particularly may stand out for patients receiving dialysis, or even just those on with kidney disease. A lot of them are included in the American Geriatric Society Beers criteria, but there are also other lists worldwide, like the Stop-Start, which provide a similar list of medications that may cause more harm than benefit in older adults. In this table, I want to highlight some PIM categories that both can increase fall risk and affect cognitive function. And you can see here there's sedatives, opioids, muscle relaxants, anticholinergics, alpha blockers, and the central acting alpha agonists. Now, a lot of this literature or evidence behind this risk has been done in the general older adult population. So some of my research has been trying to discern if we see the same risk of harm in those who are receiving dialysis. But not only that, we're trying to figure out how to implement deprescribing in the dialysis clinics. In fact, that's how me and you met, Marissa. I reached out to you to learn about your deprescribing research. So I would like for you to share what your work is in this arena, deprescribing.
Right. Thanks, Rashida. Yeah, so we did meet a few years ago, specifically talking about potentially inappropriate medications that we could potentially deprescribe in our population. So we did a national survey amongst nephrology healthcare people across Canada. And we also use different provincial databases to understand what medications would we deprescribe to our dialysis population. And so we came up with a list, and there were 9 medication classes that is really the focus of our current deprescribing efforts. And so they're listed here, and some of them you've already mentioned as well, but alpha blockers, benzodiazepines, gabapentinoids, loop diuretics, prokinetic agents, proton pump inhibitors, quinine, statins, and urate lowering agents. And so once we came up with this list, we actually developed an algorithm, and we based it on literature, some of it in the dialysis population, but some of it in the geriatric population, on how would we deprescribe. So once we developed these algorithms, we validated them, and we had professionals across Canada give us feedback on the appropriateness of these algorithms and whether they would use them in practice. And so that went through a validation. And same with the monitoring tool, what you would monitor when you would deprescribe a medication, and the evidence behind how you would deprescribe. So that was part of the package. We also created these patient information tools. So there's one example here, proton pump inhibitors. It's a 2-pager with on the last page with a link to a YouTube video that has the same information on how we would deprescribe and what the importance of deprescribing, as well as the medication itself. This also went through a validation amongst patients on dialysis across Canada. And this is the example of the actual video. So using a whiteboard, explaining the same thing as the bulletin. So our next steps is actually to use this in practice. And so this is the strategic optimization of prescription medication in patients on hemodialysis, or StopMed HD. And this will occur across 3 sites in Canada, one in Vancouver, British Columbia, one in Winnipeg, Manitoba, and one here in Toronto. And so we will implement our whole toolkit in dialysis units in these 3 cities. So we're really looking forward to this implementation that will occur coming up in September. And I'm hoping that, you and I will collaborate a bit more, and hoping that you will use some of these tools at your practice site as well.
Yeah, that is amazing work, Marissa. You guys have done a lot. And I think what's really exciting here is that this paper really provides like momentum, or the kind of information that patients and clinicians need to see about the value of deprescribing, right? Because we're showing that polypharmacy is extremely prevalent, and it also contributes to patients' quality of life. And so as we move towards a more patient-centered focus, and this is really the type of things we all should be talking about. So with that, I think we can close this video.
Awesome.
Thank you
Thanks
for
again.
listening.
Nice seeing you.